I've had the pleasure of working with Dr. Rita McCracken for several years now. And one of the things that I really appreciate is her passion for appropriate healthcare and her real dedication to making the lives of her patients better. And beyond her clinical practice, she's made every effort to learn every way in which she can do that. So she went back after a career in human resources to become a medical doctor. And then shortly after that, while raising a young family, and she went and completed her PhD in 2018. And we're very thankful that she decided to spend some of her time with the Therapeutics Initiative. I'll just read her bio. She's a full service family doctor and researcher living as an uninvited visitor on the unceded traditional territories of the Coast Salish peoples, including the Tsleil-Waututh, Musqueam, and the Squamish nations. She is an assistant professor in the Department of Family Practice at UBC and studies the availability of primary care in BC and reliable ways to measure changes in that availability. Her other research work includes assessing the effects of too much medication and effective methods to deprescribe those excessive medicines. I've always found her presentations engaging, and I'm sure you will too. And Rita, I'll turn it over to you.
Thank you very much, Erin. Hi, everybody. I'm delighted to be here. I will confess a couple of things. One, my internet has been super fritzy this morning, so fingers crossed I remain present. If I don't, I will try to reconnect using my neighbor's Wi-Fi. And the other thing is that even though I have delivered this topic many times, I'm super nervous today. So I don't know what it is about the energy of this group, although I think it's probably, I had COVID last week, and I think that this is yet another side effect of COVID, is just causing some excessive work anxiety for things that we talk a lot about and have passion about. So without further ado, I will get started. As Erin said, please throw things up in the chat throughout, and then we'll have a discussion at the end. So the title for today's talk is one that I've used before: Think Twice, the lack of evidence for opioid analgesics to treat minor and acute chronic pain. And what we're going to be talking about today is, for those of you who watch television, and might have seen the show The Office or something like it, this is like a first person kind of, I'm going to be delivering the material, but I'm going to be breaking from the material and talking about what we have learned about delivering these educational messages and how it has redirected the research that we've been doing into this work. So it's going to be a little meta. There's going to be a couple of different levels going on about it. And at the beginning, I'd like to acknowledge right off the bat, Shauna Narayan, who is here with me today. She's the research coordinator for this research project. And there she is, also feeling slightly unwell. And thank you, Shauna, for being here. And other members of my team are mentioned here. And as well, you'll see that we have collaborated with the Therapeutics Initiative and their portrait, which Erin mentioned as well. We got some funding from CIHR. The Innovation Support Unit was key early on, and as well, the British Columbia Centre on Substance Use has been very helpful. And you'll see their parts as they go through. So in addition to acknowledging that I'm an uninvited visitor on the sacred and territorial lands of the Musqueam, Tsleil-Waututh, and Squamish people, I acknowledge that as a healthcare provider, I have benefited from the privilege that I have of not identifying as an Indigenous person or a person of color. And the Indian residential schools and Indian hospitals have caused terrible damage and terrible harm. And as a healthcare provider and as a health researcher, I'm committed to trying to understand that better and actively undo it, not just observe it and not just feel personal shame about it, but to try to undo it as well. I have no financial conflicts of interest to declare. I get paid from the University of British Columbia. And as a family doctor, I get paid via MSP's, British Columbia's Medical Services Plan. And as mentioned, we have received some grants for this work. I believe everybody has bias. Everybody comes from their own personal experiences. I try to make my bias as evident as possible by constantly second guessing myself, by being open to feedback. And also some of the other more structured mechanisms that we use is to have our educational content validated by members of an independent scientific planning committee and the College of Family Physicians of Canada. And I will be providing references as well. As mentioned, these are our partners. And so the learning objectives for today's session is I'd like you to have an understanding of the potential pitfalls of well-intended evidence-based opioid prescribing education and understand what the intended learning objectives were from this work, including the definitions of opioid naive and opioid sparing, the quality of evidence for the efficacy of opioid analgesic for non-cancer pain, and the utility and limitations of risk prediction tools to figure out if I prescribe this person an opioid, what's the risk of becoming addicted, and then also to describe opioid sparing approaches. There are some critically adjacent topics that have emerged as we have been presenting this material over the last year, including non-pharmacological approaches to pain management and or barriers to those therapies, how to recognize and treat opioid use disorder, discussing prescribing for safe supply and risk mitigation, addressing tapering approaches for patients receiving long-term opioid prescriptions. And the meta level is going to be about our learning that you can't really talk about one part of opioids without talking about all the parts of opioids. So I just want to acknowledge that we won't have a chance to adequately cover all these other topics. I will mention them and how they came up as we go forward. But our colleagues at the BC Centre on Substance Use have some excellent education materials, and I highly recommend you checking those out if you have any questions on the first four topics on this slide. And just to be perfectly clear to all the prescribers here, we are not making any suggestions about withholding, restricting, or sparing opioid prescriptions for the treatment of cancer-related pain or any palliative conditions. This talk does not cover those. So go ahead and log off if that's what you were hoping for today. That is not what we are talking about. The approach to pain management for those types of presentations is completely different, and this does not apply. So I just want to be really clear about that. And absolutely a shout out to all the amazing palliative care education that's happening around the province and the palliative care clinicians available on the race line to help you sort through that. So like any good medical presentation, we're going to start with a case. Ms. M, she's a 48-year-old lawyer, a single mother with 2 elementary school kids, presented to her family doctor with bad elbow pain after she had a fall 1 week ago, a foosh. She fell on an outstretched hand. And at the emergency department, it showed a minimally displaced proximal radius fracture. She declined the opioid prescription at that time that was offered to her because she needs to keep her head clear for work and the kids. Her pain is less than at the time of the injury, and she's been getting some benefit from the NSAIDs and acetaminophen, but her sleep is completely disrupted. Typing all day is difficult, and at the end of the day, she finds her arm too painful to do any housework, and as a consequence, her life is starting to fall apart. She wonders if she should have taken the opioid from the Emerge doc and wants to know from you, would it still help her, and should you give her some today? So how can we help with this patient? So I'm a family doctor who loves to help my patients. I also have a soft spot for parents who have elementary school age kids. And I would love to be able to promise this woman unicorns and rainbows, but that almost never happens. And so we're just going to take a short little side trip here to remind ourselves about if a drug works or not. So will this drug work for me? Those of us who are prescribers and researchers in this area know that there's very few drugs that are 100% in their efficacy, almost none of them actually. And even a number needed to treat of 2, where if you were to give the medication to 2 people, where it would work in one of those 2 people, i.e. a 50% chance that it would work, that is really difficult to find. We're dealing with numbers needed to treat much higher. And so I'm going to give you a couple of examples here. Thankfully, general anesthetic for an abdominal surgery, for example, the number needed to treat is almost always 1, but you've probably all heard a story of a patient whose anesthetic didn't work and they felt pain during a surgery. If you're lucky enough to have your heart attack in a casino that has defibrillators there, you have a chance of in 1 in 2 or 1 in 3 of it working for you to have a 30-day survival. Viagra has a famous NNT of 2 to 3 for allowing sexual intercourse to be successful. And then we start jumping up. So the use of nicotine replacement for smoking cessation, the number needed to treat is about 15. So 1 in 15 people will get a benefit from it. Doesn't mean it's not a good idea. It just helps us understand why, when we prescribe something, not everybody stops smoking immediately. And similarly, why not everybody gets completely better when we prescribe a medication. So having that understanding of what do the studies tell us about how approximately effective we can expect this to be for the people who were studied. There's lots and lots and lots and lots of issues with NNT and other ways to measure it. And I just wanted to introduce this idea that it's unreasonable for us to expect that every drug that we prescribe will actually work for every person that is prescribed to. So, all right, and I'm seeing the poll. That's great. We're doing this poll to find out who's here today, and also do a little bit of a pre-post test of the knowledge of the concepts that we're going through. And at the end, I'll share a little bit about what we've seen in the other groups and how this is working. So, all right, NNT and our patient. So remember our patient, she's 48, she had a FOOSH a week ago, and she's having pain and her life is falling apart. What's the NNT for treating non-displaced upper extremity fractures with prescribed opioids? And the answer is question mark. So this is probably not a surprise, but we don't actually have good information about this. This is not a question that has been specifically answered in the literature. So what do we do then? How do we rationalize even having a conversation about this? And again, taking a step back, there has been concern, I'm sure you all have heard at some point, that prescribed opioids have been contributing to the problem of opioid overdose deaths, or that opioids are bad in some way. And so it is a very reasonable expectation that we would want prescribers to use the best evidence and prescribe opioids in the safest way. So just some foreshadowing here. There's little evidence that opioids are more effective than alternatives. There's evidence of some harms associated with opioid prescribing, and the risk prediction tools of who's going to get addicted and who's not cannot reliably identify those people correctly. So we sent out this portrait to all the family doctor prescribers in British Columbia. The portraits are now available online, and you can sign up for them instead of just getting them as a piece of paper. And what this portrait did was compare how your prescribing of opioids to opioid naive patients would be to everybody else who's prescribing in British Columbia. And this patient that we're talking about, the 48-year-old mom, she's opioid naive. So she didn't come in, she hasn't been using opioids for other problems. She has not taken an opioid. She has a lot of questions about it, and is hoping that you can help her. So when you give an opioid, I would argue you can expect this for almost every drug that you prescribe. If you haven't given it to them before, they're either going to get no benefit and they might have some side effects, or they might get benefit and everything goes okay, or they might develop some kind of problem with the drug. With regards to opioids, there is a possibility that they could go on to develop an opioid use disorder. And there is also a group of people who, 5 years ago, I remember I broke my toe on vacation and I used 7 Tylenol 3s and everything worked out really well. I actually, that helped me get over the problems with my sleeping. So that's a different kind of story. And in primary care, we have the benefit of this longitudinal relationship, which can really provide an extra bit of information about how and when these medications are going to work. So opioid naive, I've mentioned it a couple of times, and it's on the title of the portrait. And so I just want to get really specific about what we meant in this particular project. It definitely depends on who you ask. But for us, it meant that a patient who has not been prescribed opioids for at least the last 6 months. And so let's imagine that you had, if as a prescriber, you had the time to go to the literature and do a complete literature review for every patient question that emerges for you, which I fully acknowledge is 100% not possible. But if you did, if you went and you looked for high quality evidence about what and how to prescribe opioids for non-cancer pain in primary care settings, you're going to be pretty disappointed. There is evidence, but I mean, it honestly looks a little bit like a black hole of knowledge. There's so much more that needs to be done in this area. And so reviewing the evidence was a little bit painful for us when we were putting together the portrait. And as we've been talking about it as well, this is a drug that has been around for literally thousands of years. And yet we have a fairly stringy looking pile of evidence. So here's what we do know: acute pain evidence. And so taking a break here from teaching about this and talking about the research process, the papers and the studies I'm going to show you, I picked on purpose, not necessarily as the highest quality of evidence. So as one would for a critical appraisal of a topic, I tried to pick studies that we could use that would translate to a clinical scenario, and that were also representative of what the larger body of evidence shows as well. So we have this nice systematic review here that shows oral NSAIDs versus other oral analgesics for any acute soft tissue injury. So this is soft tissue injury. This is not minimally displaced fractures, but they're very similar. If you didn't have an X-ray, you might say that it's a soft tissue injury for this particular patient, and the treatment would probably be very similar. So the conclusion from this particular study was that compared with opioids, that compared with acetaminophen, NSAIDs make no difference to pain at 1 to 2 hours and at 2 to 3 days, and they may make no difference at day 7 or beyond. And that compared with opioids, NSAIDs probably make no difference to pain at 1 hour. Essentially, what we're saying is that there doesn't really appear to be a difference between NSAIDs and opioids, and neither of them really seem to have much effect on the pain. But if you had to choose between the two, NSAIDs are probably a wiser choice because This interesting study, so this is a cohort study, so it is not based on randomized controlled trials, and it's not a review of observational studies that you might see in a systematic review. But what this looked at was they followed a bunch of people who showed up to emergency and who got with acute pain and who got prescribed opioids. And what they found was that constipation, nausea, vomiting, dizziness, drowsiness, and weakness was much, much higher in people who were not prescribed opioids or were given NSAIDs or Tylenol. So all of the usual caveats about cohort studies not being the same, having the same ability to rule out confounders. But this is an important observation that those of us who are prescribers are probably like, oh yeah, constipation for sure. I remember that one time I forgot to mention constipation side effect, and then I get the patient coming back 7 days later, terrible abdominal pain, hasn't had a bowel movement in 6 days. So opioids are not benign, which I know nobody showed up here thinking that, but I like this one because it quantifies that these things are real. The side effects are real and they happen at a relatively high rate. Okay, so chronic pain evidence. We all know somebody who has been prescribed opioids and they are able to live a better life as a result. And that is amazing. And 100%, I am not ever suggesting, nobody from the TI, nobody from the university is saying that that person should be tapered immediately off of their opioid and that they are getting bad care. No, absolutely not. What we're talking about is, should opioids be the gold standard of care? Should we be offering it to everybody who has chronic pain, who shows up, and we can expect that it's going to help them? And sadly, the answer is no. And there is, so I think I've mentioned already that many of the studies that we have are stringy, i.e. problematic. This particular trial, the spaced randomized controlled trial, it was a good clinical trial, but it was not perfect. So what it did was it followed people with chronic pain from hip and knee osteoarthritis, followed them for 12 months, and it took a look at how do people who get prescribed opioids, how does it affect their function and their pain? And is it better than people who got randomized to not getting opioids? And so that's a really helpful question for us to know that. So certainly, again, absolutely, we know that there are some people who benefit, but then you also have probably heard of people who the opioids are not working and it's not helping them. And if you're thinking, well, maybe if I just escalate the opioid, would that work? And this trial suggests that the use of opioid medication did not result in better pain-related function. This is a wordy slide, I admit it. All of the materials are available for you to review afterwards. Essentially, this just gives you some more detail that if we were, the trial was to look for pain-related function, and there was no difference between the group. What they used as significant difference was a 1-point improvement on a 10-point pain scale. So that's, how's your pain today on a scale of 1 to 10. Just going to check in here. I saw my screen freeze. Could someone tell me if they can still hear me?
I can still hear you, Rita.
Thank you. Okay. So 1 point on the 10-point scale is what was needed for an outcome to count. And you need to ask yourself, imagine you're experiencing 8 out of 10 pain. and someone offers you a medication to take it down to 7, we can predict that it's probably going to take this down to 7 for you. That's not like a super meaningful difference to me when I'm thinking about myself in pain, but that's what the outcome was that was measured here. So when we say that it was significant or not significant, this study could not even find 1 point on the scale difference in pain-related function. And I've got another slide about how the pain gets measured. And I acknowledge that I sometimes wonder if putting it on a chart makes it more difficult to understand. But back to what I was saying before, that we've got the no pain at 0 and pain as bad as you can imagine. And the people who participated in this study were asked what their least pain in the past 24 hours was, what their average pain in the 24 hours, and what their worst pain was in 24 hours. And so that was the scale that they used. And what these are the results. So the top bar is people who got opioids for both of these representations here. And the top one is about pain and the bottom one is about function. And so what you can see, we'll just jump to the function one here, is that you'll see that at the beginning, people's pain was about 5.4, interfering with their ability to do the things that they want to do. And it drops to 3.4 by the end of the trial 12 months later. Interestingly, for non-opioids, it goes from 5.5 to 3.3. And so that suggests that we probably have some other effects besides the opioids that are mitigating that pain, that are decreasing that pain and its effect on the function. And as a clinician, I'm happy to see that generally over time, people's experience of pain that is interfering with their life is decreasing. But I can also see that opioids are not a guarantee that that's going to work. And so there are systematic reviews, as I had mentioned, of this material, and they generally are finding the same thing, that opioids do not make significant changes to people's outcomes that are measured using these pain scales and other imperfect representations of how pain is affecting somebody's life. So we are able to use some of these systematic reviews to calculate numbers needed to treat, to just go back to that. And so what we can say for chronic non-cancer pain is that a reasonable estimate of number needed to treat for the opioid helping is 8. So we could give the opioid to 8 people and 1 person is going to benefit. And I'd say as a clinician that that NNT actually seems a little bit high to me. I feel like maybe I'm screening people out a little bit more effectively to give opioids to the people who I think it's really more likely going to help. And again, I have the benefit of the longitudinal relationship. I'm not a magician, but I've known my patients for years. And if I'm just getting to know them, I am staggering a bunch of visits for us to get to understand their pain a little bit better. How it affects their physical function, a number needed to treat of 12, and then I feel a little bit more, it's really hard. Chronic pain is a terrible condition to live with, and getting people to feel more functional and having resources to be able to do the things they want to do in their lives, it is tricky, tricky stuff. Opioids in the assistance of role function. So that's, can I attend to my personally defined duties as a homemaker, or in my job, will the drugs help these? And it's a pretty high number needed to treat. Also important here to go down to the side effects and the number needed to harm of somebody feeling really unwell, so unwell they would stop taking the drug, is between 14 and 29. So, and then risk assessment evidence. This is the super handy screening tools that we love to think are going to work. I love a nice screening tool. It just helps me formulate my thoughts. The patient feels really listened to. And unfortunately, what we have found is that the tools that have been developed for identifying people who might go on to develop an opioid use disorder from a prescription opioid is that the results from these tools cannot be depended upon to correctly identify who is going to be at higher risk. And I think if we stop and think about that for a minute, that shouldn't be too surprising, because obviously, opioid use disorder is very complicated. If it was not complicated, we would have figured it out 6 years ago when the public health crisis was first declared in British Columbia. And instead, here we are now with 6 people dying a day still, and we haven't figured it out. A risk prediction tool is not going to help with this problem. So, taking a pause for a moment. Research suggests that prescribers should think twice before prescribing opioid analgesics to opioid naive patients. Guidelines and practice standards recommend understanding the risks prior to prescribing opioid analgesics. Tools and strategies for identifying patients at high risk of prescription have not been rigorously reviewed or evaluated or validated. All right, and so time out for a little bit of a meta moment here. What we found as we were doing these webinars, and this is the 8th webinar in a year, delivered primarily to people working in British Columbia who are primary care prescribers, nurse practitioners, family doctors, residents, or physicians who are working with a focused practice in addictions. And what we found is that you can't talk about prescribing opioids for acute or chronic non-cancer pain and not talk about opioid use disorder and prescribe. It all just gets too mixed up. That having the message, hey, prescribe safely, try to avoid prescribing opioids if you can, somehow for some people is getting translated into, I should never prescribe opioids. People who are asking me for opioids are drug seeking, and it is a problem that I should be on high alert for. So this is a problem. This is a real problem. So what have we been doing about it? We've seen in British Columbia, physicians are licensed by the College of Physicians and Surgeons. And in June 2016, a very aggressive practice standard was published that actually put limits on the number of milligrams of morphine per day that could be prescribed to patients, especially with combinations of other sedating medications like benzodiazepines. And almost immediately, we started to see some problems with that rigid interpretation. We saw people being rapidly tapered or just discharged out looking for new prescriptions because their physicians had been told by their licensing body, you can't do this anymore. That, of course, was never the intention. And there's another research project that I've been doing with a colleague at McGill where we are actually looking at the administrative data and PharmaNet data to see just how many individuals were affected by that unintended consequence of the practice standard that was initiated in 2016. So we're looking at that and we'll be able to quantify it. Don't have those results yet. You can see that this was last revised March 9th, and the language has been softened considerably. The language is now much more about being a reasonable prescriber and documenting why it is you're doing what you're doing. However, as I mentioned, we still have 6 people dying a day, and they're not dying from prescribed opioids. They're dying from a toxic drug supply that is being supplied by organized crime and is not being regulated. So imagine if we had 6 people dying a day from red wine or gin that was being inappropriately prepared and then sold to people, and they were dying from consequences of using that non-safe supply of alcohol. We would be completely up in arms. And our safe supply sites, bars, would be organizing in order for us to stop this. But instead, we have this decades-long stigma building issue around people who use opioids, and it's creating this friction with us actually creating a solution. And in the discussions that we've had through this webinar and the focus groups that we conducted after it in the fall of 2021, we realized that we really needed to stop talking about worrying about opioid naive people. And we really needed to start supporting the conversation about how do we make sure that every person who is showing up to a primary care prescriber is getting the care that they need if they have anything going on with using opioids. So if they are an opioid user and they are interested in prescribed safe supply, that we need to take a look at how can we make that easier for them, rather than just saying to everybody, hey, opioids are bad, stop using them, which of course was never our message. That was never our message. We had well-researched messages that have been tested in other regions, and maybe 10 years ago might have been the messages to give, but now they are not. And we're seeing, so I mentioned the study that I'm doing with my colleagues from McGill around looking at people who've been discharged inappropriately. We also have some studies that are being done using large data sets that show that as the messaging regarding opioid prescribing has been increasing and prescriptions start coming down, we are actually seeing deaths from opioid related overdose increasing, which is super worrisome, absolutely super worrisome. It's the opposite of what we wanted to have happen. So I'm going to summarize these messages, and then we're going to go back to our case here. There's little evidence about how to prescribe for acute pain in community-based care. What we do have suggests that NSAIDs and acetaminophen are as good or better than opioids. Chronic pain has a slightly higher quality of evidence, but concludes that opioids do not routinely improve outcomes. A systematic review found there's no reliable tools to identify those who might develop opioid use disorder. We have these complications in our prescribing environment, like the practice standards provided by our licensing bodies. We've got an opioid crisis, a toxic drug supply, the possible new relationship between prescribed opioids and opioid-related emergency visits and deaths. And we're sending this portrait out, telling prescribers, you should change how you prescribe. So it is very complicated. It is all well-intended. It is evidence-based, but what do we do? And to just bring it back to, the majority of patients that we're seeing in primary care are a little bit more like Miss M and a little bit less like somebody who's at higher risk for death from a toxic drug supply. But those people are important, and they are dying from their lack of appropriate healthcare. Okay, so we remember who Miss M is and how we're going to help her. In general, with my patients, I try to review the evidence, listen to what she says, and come to a shared decision. And so I might say something like this to this patient. Sounds like you've got a lot on your plate, and a broken arm was the last thing you needed. I wish I had a magic drug to prescribe to you, that unicorn and rainbow, but I don't. We've got limited research about people in your situation and whether an opioid would help or not, or it might just cause more problems. Frequent side effects from opioids include sedation, impaired thinking, constipation, nausea, dizziness, and sometimes people can even develop a dependence to the drug and may go on to develop an opioid use disorder. And we have no way to really predict who that's going to be. Pain from your injury will continue to improve as it heals. Discomfort is usually the worst in the first week after the injury. The studies that we do have suggest that what you've been doing right now with your ibuprofen and Tylenol are working as well, or maybe even better than an opioid. What do you think about that? How does that information help you with where you're sitting right now? And depending on the patient, they might say to me, oh God, I don't know. Will you give me your advice? And I'd say, okay, well, my advice is that we continue with what's going on right now. Or, maybe I've had a look at this injury and there is a significant number of amount of swelling, and maybe it's not quite as non-displaced or not. And so I might prescribe an opioid sparing amount of opioid to her. And it's going to be a shared decision, and I'm going to document it, and I am going to ensure that the patient understands what is reasonable to expect, what reasonable expectations would be from it. Sorry. So I have this, this is a template that I actually have in my EMR. Happy to share it with everybody. It's included as part of the materials on the TI website. Includes all the elements required by the BC licensing body around rationale for the prescription, expectations and goals of treatment, med safety, discontinuation, additional treatment strategies discussed today. And I just erase whatever I don't need, which is usually most of this, but then I've got it all. I also include a handout that I give to patients. And opioid sparing. All right, so we're back to it. What does opioid sparing mean? It's when opioids are indicated, prescribe the smallest amount for the shortest period of time. And I will just put in a caveat that there's actually no evidence that codeine or tramadol is safer than more potent opioids. So all of this applies to those as well. You might be thinking, oh, well, I'll just use Tylenol 3 then, or just use Percocet, or just use Tramadol. We don't have any good evidence that those are actually any different than hydromorphone or morphine. When we were doing this portrait, I spent a lot of time looking for definitions in the literature of opioid sparing, and I can tell you that there wasn't any then. That was about 1.5 years ago that I last looked. I don't think there's any now, but what I did find was some small interventional studies that were done in hospitals where they were trying to reduce the number of opioids given at time of discharge. And these are some examples that were very close to how I prescribe opioids in these situations. So Tylenol 3, 1 to 2 tablets, PO, Q6, and a MITE of 20. Or if somebody has much more significant pain, hydromorphone 0.5 PO Q6 hours with a MITE of 15. Those are 2 examples. And I want to be extremely cautious in saying these are not evidence supported opioid sparing. We do not have any of those, but we want to try to give the smallest amount possible. And if we're following up with our patients to find out how things have gone, we're going to figure out if that was the right amount for that person, or if we should have done less, or if we should have done more. This is a handout that I've used to give to patients, just like Ms. M, which just summarizes everything that I have in my note about what they can expect from their medications. Okay, so I have reached the endpoint of the standard webinar about this, and I think I have emphasized the points about the well-intended educational messages that are based on evidence, that we want to try to avoid opioids when we can. But I've also introduced the idea that we're having issues associated with the messages going awry and being interfered with other issues in society. We did a special seminar with UBC Health. And Shauna, I'm wondering if you wouldn't mind finding that link and putting it into the chat. Where we did an open dialogue with public, and we talked about, so why is this happening? What do we think we need to be doing in order to change research agendas so that we're not making these well-intended evidence-based potential missteps that could be leading towards messaging that's possibly exposing more people to harm? And perhaps not surprisingly, in this day and age. The topics of racism, colonialism, and mental health stigma all came up from this from this work and this talk. And we have been modifying what we're doing to give close consideration of those concepts and how we're going to be structuring future research going forward. So we have our qualitative results from the webinar that we are writing up. We have a couple of papers published already, which I'll make sure are connected with the materials on the TI. And then we also did this randomized controlled trial with the portrait, and we're just analyzing the data for that right now. So I will stop here and would love to hear comments, see if there's any questions that came up from the, wow, 104 participants. Thank you so much to everybody who has shown up.
Yeah, thank you, Rita. That was fantastic. Lots of information. You're on time. Lots to think about. Maybe I'll start off with the questions if you don't mind. So I was wondering, you've presented this 8 times before. Were there certain themes that you recall coming out of those 8 sessions, like the major concerns, the practical next steps moving forward, the common questions that came up?
Yeah, 2, the inherited patient who comes on high doses of opioids plus or minus problematic adjuncts like benzodiazepines, or being a locum and being asked to refill those medications where you don't have the relationship. So you don't know, how is this working for this person? What's going on with it? Coupled with the pressures from the college or perceived pressures from the college. Like, I attended this one CME and they said, never do this. And so I never do this. And then the third element is people not knowing how to identify opioid use disorder and feeling that there's a big barrier to identifying it and treating it as well. And so kind of being like afraid that if you ask about it, you might find it. And so better to just not prescribe any opioids, which, as we can see, probably leads to some problems.
Sure. Yeah, very interesting. There is one question in the chat. Do you think provincial coverage for physical therapy could be helpful?
Yes, absolutely. Non-pharmacological treatment for pain, or access to non-pharmacological treatment for pain in British Columbia, is garbage. There is excellent resources that are set up, and their waiting times are miles long. They're centered in urban areas. They have not paid particularly attention necessarily to issues associated with access, like if you miss an appointment once, you're out. Services aren't provided in more than one language in most of those places. So it would be great if we had those resources accessible, and we don't have a lot of them right now, and it is a problem.
Okay. Another question: any evidence available that buprenorphine is a safer treatment option than other opioids with regard to adverse events?
For acute and chronic pain, you know what, I don't have that to top of mind. I'm suspecting not, but I can't say for sure. It's an excellent question. If you wanted to follow up with an email, I'd be happy to figure out where we could figure out the answer to that.
Okay, thanks, Rita, for that offer. I'll give you a chance to get a sip of water and just remind everyone that if you are interested in the continuing education credits, please complete the evaluation that we'll email to you and send it back to us. And within a week or 2, we'll get you your credits. But even if you're not, we're really interested in your evaluation comments so we can continually improve.
I see a great question from a nephrologist who saw elderly patients and the NSAID problem, and would opioids be considered? Absolutely. So up until a year ago, I had a long-term care practice in addition to my full service family practice. And chronic pain is like, it is a problem. And it is not right that we don't treat it. I used a lot of what my trainees would refer to as a homeopathic dose of hydromorphone. Do a trial for 2 weeks of, for example, 0.25 of hydromorphone TID. Set the expectations that what you're hoping is that there's going to be less grimacing, calling out during personal care. For somebody who's ambulating and still able to make it to dialysis, I'm sure you could have a parallel set of outcomes related to function and ability to enjoy life. So absolutely, I think that it is reasonable. And then just do it for that short period of time. And then if it doesn't work, you just stop it. But if it works, there's no problem with that. If we are alleviating someone's pain and we're not increasing their mental fog and we're allowing them to get dressed or in and out of the taxi to be able to make it to dialysis, then 100% we should be doing that. That is our job. We are supposed to be alleviating suffering.
A really interesting question here about any insight onto why physicians have such variable prescribing practices. Two different physicians can provide two totally different prescriptions. And then the second part of that question is, are they being taught that non-pharmacological solutions are just as valid?
Oh, great question. So answer to the first question, who the heck knows? That's a big question. We definitely found that. So we did a prevalence paper where we actually studied the rates of prescribing before we made the portrait. And again, I'll make sure that paper gets linked to the TI materials as well. You could take a look at that. There's a wide variation in how people are prescribing opioids for sure. And the one of the action points that we have taken out of this research is we're working very closely with the family practice residency training programs so that we can help them get connected to opioid agonist therapy training and trying to make that whole opioid picture look more like one. And we're finding that we did some focus groups with 17 residents from across, or maybe 20, I can't remember, 20 residents from across the province. And we found wide variation in what they're getting taught and how that is being absorbed personally, and the clinical experiences that they're having. Resident told me who just said, I never do it when patients are discharged. Never. I just never do it. And I'm like, that seems like a very fixed stance for a surgeon to take. And I can imagine that if that's the teaching you've had and that really hit you in that moment, that that could be a problem.
Rita, we have
my internet is unstable.
Yeah, it's working okay. We have like 4 minutes. Can we do a rapid fire to cover the last few questions? What about giving people opioids just to sleep in an acute injury?
I'm sorry, my internet is freezing up. Is the question? Can you hear me? Okay, Aaron.
Yeah.
Okay, great. Sorry, is the question in the chat?
Yeah. So it's 2 parts. What about giving people opioids just to sleep for example, in an acute injury?
Yeah. If you like, if all the stuff that we've said, and at the end, and if you're like, you've explained it all to the patient and they're like, I need to sleep and the pain is so bad, why not? Why not do a short course of, even just giving them 3 or 4 tablets and saying, let's have a phone appointment to follow up in a couple of days.
Okay. Should we be concerned about longer use of NSAIDs greater than 48 hours and the impact on healing, bone healing?
No, that my understanding. So I reviewed this quite a while ago during my PhD work, and that has been debunked. That there is no connection between NSAIDs and fracture healing. So now there definitely are side effects from NSAIDs that we should 100% be concerned about, like all the GI stuff, bleeding, everything like that. But no, the fracture has been there is no connection.
Okay. And maybe because we're just about at the end of time, I'll end with a nice comment in the chat. So true, Dr. McCracken. Every intervention is indeed a trial of therapy, and we need to always consider whether the trial is effective or not. So Rita, again, a very engaging presentation. I'm not surprised. You're very good at this. Thank you so much for your time. And thanks to everyone that took the time out of their day to spend with us. Hopefully you'll connect with the TI again in the future, and have a lovely afternoon or rest of the day wherever you are.